Thank you so much, Vardhaman, and thank you so much, Namrata ma'am, and everyone else at MOS and AIOS for, giving me this mantle, I should say, to sort of dissect some of what we are going to discuss today. All right, I'm going to start with a quick drum roll so that whoever is dozing a bit should be up and running. Right. So we are discussing pilocarpine and presbyopia. Enough of that. Right. So what we are really going to try and understand are some of the clinical trials that are. Just a second. Yeah. We're going to try and understand some of the clinical trials that have been done on pilocarpine specifically for the use of presbyopia. As has already been reiterated before, that pilocarpine has been around for decades, like 50 years, right? So pretty much the oldest anti-glaucoma medication that is known to us. And it had gone a bit quiescent, like many diseases, but now it has come back with a roar, and we are looking to use it for management of presbyopia. So let's understand how these clinical trials have worked, and then we can deliberate whether we should adopt it or not. And hopefully we'll get a good idea of where we are and where we are going. And so the idea also is to sort of teach you how to fish and not to fish for you. So sort of how to interpret clinical trials in general, not only for this, but on a larger scale. So because we're going to come across trials all our lives, right? So hopefully I'll be able to sort of transfer some of these templates which you can use to interpret clinical trials as well. So let's understand that wearing glasses is a bit of an issue. If we know that beauty lies in the eyes of the beholder, so someone who is very sort of glamorous and wants to be in the forefront is never happy to wear glasses or hide behind glasses. As you can see, this film star on the extreme right is in glasses, and so the image just says it all. And first thing and foremost thing is that we need to realize as physicians that the problem is real, right, for a patient. And so we need to do something about this, and I'm really happy that we are already underway and that there is something already coming up, and we'll see where we are and where we're going. So, as Vardhaman has already introduced me, so I'm predominantly a vitreoretinal surgeon practicing in Mumbai. And, quickly, I would like to sort of just remind you all that try and keep your microphones on mute. Some of my financial disclosures, though nothing is relevant to today's talk on pilocarpine. And quick disclaimer is that, all the interpretations and thoughts that I'm going to sort of talk about today are mine alone, and, neither has AIOS, nor has MOS, nor has NTOD or anyone else actually interfered in any of the things that I'm going to speak. So, hopefully I'm going to make sense to all of you in general coming from a clinical trials point of view. So what is presbyopia? Quickly, so, let's try and understand what is this presbyopia, and so that we actually fathom what pilocarpine is doing internally, and also that some of us watching might not be from the medical fraternity, and maybe from the general public, and so let's quickly understand what is presbyopia. So the eye is really like a lens, and it focuses, and like any other lens, it also has an aperture in the center which is called the pupil. So this is the lens aperture of a camera. So the pupil in the eye does the same job, where the pupil actually dilates or enlarges if there is very dim light, and it constricts or contracts when there is a lot of bright light. So it basically is a regulator of how much light goes into the eye. And in a real human eye, this is what you can see. The pupil is actually going small, and this is in response to something which is coming close to you, not in response to light alone, right? So the pupil is one factor in seeing near vision. So near vision really is not just about the pupil, and we call this accommodation, and it's about the pupil as well as the ciliary body. So what is the ciliary body? I'll quickly show you a video which I've borrowed actually from YouTube, and I've given some attributions to it. So let's understand what is accommodation, how it happens, and then understand how pilocarpine works.
The engine of accommodation is the contraction of the ciliary body mediated by the distribution of forces via all elements of the zonular apparatus. The resultant changes in refraction are due to the increased thickness of the lens and the increased curvature of the anterior and posterior capsule. The complex anatomy of the vitreous zonule results in traction on the vitreous membrane peripherally, and traction on Weigert's ligament connecting the posterior capsule and vitreous membrane.
And this is really exactly how accommodation happens. This is contraction of the ciliary body. The posterior zonules are contracting and there is traction on the peripheral retina, while the anterior, I'll just quickly play it again. So, this anterior zonules are going to relax, and that's what is going to cause the lens to bulk up, and the posterior zonules are going to contract. And when there is ciliary body relaxation, the anterior zonules contract and the posterior zonule relax. So you can clearly see that there is some amount of traction which is happening on the periphery, as well as all of this is. So essentially what pilocarpine is doing is leading to pupillary constriction. It is also leading to ciliary body contraction, tautening the posterior zonules, which is causing some amount of traction in the retinal periphery, and is leading to relaxation of the anterior zonules. And all of this together is leading to swelling of the lens or increase in the anterior posterior diameter of the lens. Right. So as we know, with aging, this this increment in the anterior posterior diameter of the lens suffers. And that's why most of us start getting presbyopia by the age of 40, because the lens becomes less and less elastic with age. So interestingly, this was a very old paper on pilocarpine, and what it has done is looked at 4 concentrations of pilocarpine in normal subjects, and it actually says that normal pupils constrict to dilute concentrations of pilocarpine, including 0.25%. Remember, today we are talking about 1.25%, but then normal pupils constrict with even 0.25%. Even half of that, and even half of that, and even really half of that, right? So then why do we need 1.25%? So I'll show you some trials which have actually used 0.4% and have been relatively successful. But just that, these lower concentrations may cause pupillary constriction, but may not cause enough ciliary contraction, right? So accommodation actually may not be happening, right? So therefore we need slightly stronger concentrations. So with this in mind, let's remember also that if it's a rigid pupil, that pupil is not at all reacting to light, it's already small right from the beginning, the chances of all those mechanisms happening internally are not that high, because the pilocarpine, it's already small enough, and most of these patients may not even ask for presbyopic corrections. So, like I said, let's jump into some of the clinical trials that have been published so far. Some basics are, most of these clinical trials use Snellen's acuity for their presentation of results, while we use mostly Roman or Jaeger acuity. So 2040 in US Snellen's is N6 for hours or J5, and in 2030 is N5 or J3. And as the number increases, the visual acuity gets worse and worse. So 20/60 is N10. And most patients in these trials are perhaps at this level, at about N10 uncorrected, right? So just a quick basic before we go into, dive into the results. So these are the 4 trials that we are going to discuss today, and, using a same template, and then, we can actually, in the end, compare across all of them. So the first one is, of course, the GEMINI phase 1 clinical trial, which has been published in 2021, and then, the drug has received, US FDA approval and has been used for the past 3 years in the US, has been marketed as well. And the other is the Virgo phase 3 trial. We'll talk about these. The other is NEAR phase 3 randomized control trial, which has been recently published, as you can see, 2024, and then some of our own data from trials which are conducted in India. So so hopefully I'll be able to give you a template. So template to apply clinical trials, and then interpret all these published results together, and then hopefully derive some guidelines across. When we look at all these trials together on one screen, we'll be able to tell what works, what doesn't work, and how much it works, and then some take-home messages. So 5 steps to evidence-based medicine or to apply trials, is to look at the inclusion-exclusion criteria of the trial and see if your patient would actually be part of that study. It will be relatively broad. Then look at how similar your patient is to that patient in a clinical trial. So what does an ideal clinical trial patient look like, and how much variability does your patient have with that ideal patient? So is your patient really an ideal patient as part of the trial? And then you look at all the interventions which are present in that study. So in this case, there are only 2, right? It's either pilocarpine or it's not. It's either a vehicle or something else, or placebo. And then you look at your results and see, if you treat like the study said, your outcome should be like the study, more or less, give or take. And if you find a lot of differences, you should think about publishing your own data that, these guidelines have been given and I'm following these trial protocols, but it's not working, right? So let's look at the GEMINI phase 1 trial, which is, the phase 3 trial, that's GEMINI 1. And, so the drug actually was called AGN 190584. The trade name is Vuity, and it's 1.25% pilocarpine and manufactured by Allergan, which is now an AbbVie company. So this is overall, some of the outline of how the trial was done. So 323 patients were enrolled, a relatively good number. 163 got the drug and 163 got the vehicle. It's not really placebo. It's a vehicle and it's a proprietary vehicle. We don't know what contains, what are the contents of that vehicle. And I'll give you some perspective on what I think might be there. And it's not just distilled water. And then about 161 and 153 completed 30-day follow-up. That was the time when all the results have been computed and published. So this is the template that we talked about. So what were the inclusion-exclusion criteria of this trial? So this were patients between 40 and 55 years of age. Of course, they are in the presbyopic age group. So they were in relatively good health, and they had confirmed presbyopia. That as a definition, that is using the NEI-VFQ questionnaire, where at least one question between question 5 and 7 had a particular score, right? So this is all confirmed. It's like may or may not be. It's not like that. So all of them actually had confirmed presbyopia. And they were between -4 and +2 diopters for distance correction. So anyone who was little highly myopic or -5, -6 were actually excluded, and we need to remember that. And that best corrected vision, distance vision was 6/9, and mesopic near vision. Mesopic means looking at vision in dim light was supposed to at least be N14, right, or between N5 and N14. And photopic near vision, which we really check in our clinics, which are well lit, all of them should have at least N6 or even better, right? So this is pretty much what we would also look at when we are doing our patients. Now, how was an ideal trial patient in this? So most were 50-year-olds, otherwise healthy. Most were white, and more than 70% were women in this trial. So we are looking at a 50-year-old, otherwise healthy white lady who is mostly emmetropic, because most of the study patients were emmetropic, and had a baseline uncorrected, or that is distance corrected near visual acuity. That is, you're wearing your distance glasses if you have any, and they were either between N10 and N12, somewhere in that range. So this is an ideal patient. If you think about your patients who are coming to you, instead of the white, if you make it Indian, and the lady or gentleman perhaps doesn't matter, right? So this is pretty much what an ideal patient would look like in a trial, and then you need to match it with your ideal patient. So if somebody who is 42-year-old comes and who has a vision of N8, we don't expect trial results similar to this. Similarly, if somebody is 57 and has a uncorrected vision of N24, we perhaps don't expect so much improvement, or the improvement that happened. And of course, we know there are two interventions. One is the pilocarpine arm, which is the Vuity, and the other is the proprietary vehicle, which we don't know what is there in that, but it's not pilocarpine. And then we'll look at trial, outcomes. So, let's quickly see that. So this is a sort of screenshot from the actual study. You see the mean age is about 49, like I said, about 50, and if you see females is about 72.8 or 73%. So a lot more women than men. And then if you see they are whites, about 90% are whites, right? So what I have tried and done is crystallize all of this into an ideal patient, and then I have presented that to you, and then they have talked about what were their baseline visions, etc. Now let's look at the results. Before we go to the results, I want to quickly tell you about the outcome measures. So if you look at this slide, the background is a little bit, the contrast between the foreground and the background isn't that great. What if I make it like this, where the outcome, the background is white and the text is a little grayish, and you're finding it hard to see, especially if you're on a mobile phone. So this is low contrast near vision. So the font size I have used throughout from now on is actually N6 font size, just to match it, and for you to actually sort of have an experience, especially if you're sitting about 40 centimeters from the computer screen or from your mobile phone, right? So this is not really ideal. So this, if you actually test this, then you're going to get a lot of failure rates. What if I do this, where this is high contrast now? So what the trial actually used is high contrast near vision tests. And the room light may be dim or bright, but the near vision charts that were used were something like this. So what if I make the background again like this, and now what if I make the background like this, right? So this is essentially what there will be differences in your room illumination, and that will influence results. What if I make the screen totally dim like this? This is about 10 lux, and this is about N6 size. Though it's a high contrast background, this is what was actually tested as a primary outcome, which was put forward by the FDA. So it's a really high it's a high, if you take off if those who are emmetropic and not wearing reading glasses, if you take off your glasses, you will realize that, this is very hard to read, especially, that I have dimmed the light, and this is bright light. So this is about 250 lux, right? So the primary outcome is 3-line improvement, or from most people it was N10 to N5 in dim light. Right, so we know the ideal patient is 50-year-old lady who is white, has a baseline uncorrected vision of N10, is mostly emmetropic and has a mixed or brown or light colored iris. And so how many actually got to this time point? At 1 hour, only about 40% saw this. Right, so that's relatively, it's not that great. It's only about a third of patients compared to about 15% in the vehicle. So that's also quite high, right? So something is in the vehicle which is causing people to see, somehow a little better. So the difference is about 25%. At 3 hours, the effect is starting to wane slowly. That's only 31%. So really at 3 hours, only about 1/3 of the patients will see. Right, so 2/3 are going to be unhappy. Right, so then we are going to get phone calls and saying, oh, it doesn't work. But remember, the bar is set really high. Right, and then at about 6 hours it's almost gone, and then they'll have to re-put it again. What if we drop the bar and say, instead of 3 lines, if we say 2 lines, N10 to N6, so from N10 to N8, N8 to N6, so only 2-line improvement but in dim light. Now that is all right. I think from a clinical point of view, even 2-line improvement is pretty good. Now what happens there, so this is a graph showing that 40% improved at 1 hour, and that drops gradually as time goes. If you drop that bar and say only 2-line improvement, that is getting to N6, which is pretty good, that number jumps. At 1 hour, about 68-70% are seeing well. At 3 hours, still 55% are seeing well, compared to about 30%. So these placebo numbers or the vehicle numbers are also relatively high. But still, let's concentrate on the pilocarpine numbers. At 6 hours, still about 40% are seeing well. Right? So, for outcomes which are clinically more relevant to us, 80% will see well at 1 hour, right? And they'll pretty much be able to do all their activities. At 3 hours, still 60% are seeing well. So, if we counsel them in this manner that, okay, this is what you are expected to see, with very little chance that they're going to call us and say, oh, I'm not seeing well, right? And because we know what to expect, at 6 hours still, about, it's little lower than 50%. So, it's starting to wane, and this is the time point when perhaps repeat treatment might be necessary. Okay, now we have only looked at dim light, but then a lot of our patients, and including us ourselves, work always in brightly lit rooms. And if you visit a typical American home, they are all very dimly lit, but you visit a typical Indian home, it's very brightly lit. So what happens in bright light and how many actually get to N5, that number is very high. It's 92%. So almost everybody who takes pilocarpine, right? So at 1 hour, almost everyone is going to see well, especially if they are in bright light. At 3 hours, it's slowly starting to wane. At 6 hours, it's still high. Right, so if you tell people that you can, if you want to use it, you need to be in relatively bright conditions, and then, you need to have good contrast between what you're seeing and the background, it might actually work pretty well, right? So this is overall, the results from the GEMINI study in terms of how much improvement there is. Remember, the primary outcome bar is set very high, but from clinical point of view, this is something that, we might actually talk to our patients, and maybe even this is something that we could convey to them. The pupil size, of course, constricts, and that's sort of proof of concept that the drug is really working, right? So this is comparison between mesopic and photopic pupils, right? So if you see the baseline pupils are almost more than 4 millimeters. So we know that the Caucasian eyes or the white eyes, like predominantly white people, have very large pupils. So non-mydriatic imaging works very well in them for fundus imaging. Whereas dilated imaging is required for Indians. We typically have baseline pupil sizes of less than 3 millimeters or anywhere about 3.2 millimeter, right? So even mesopic, so photopic pupils are going to be even smaller. So but overall, this is where the pupil size mattered. So this is where we are. So when patients are in bright light, they actually seem to be doing well. If they're in dim light and they are expecting only N6, which is also pretty good, they will probably do well as well. At 1 hour, 100% patients said they are satisfied. And at 3 hours, about 70% patients said they are still satisfied. Right? So this is really coming from these results, or perhaps even these results, and not from the primary outcome. Right? And adverse effects, about 14% had headaches. Most of them are mild. And 7 to 8% had blurred vision for distance. We know that, constricting the pupil a lot will cause a little bit of blurring of vision. Sometimes it can even improve vision with the pinhole effect. And, that did not happen in this study. But overall, this is the results from the GEMINI study. Let's look at the Virgo study. So this is twice daily dosing of 1.25% pilocarpine, right? So you give, and then, as we've seen, the effect wanes at about 4 to 6 hours. So they have given another drop at 6 hours time point. And let's see what happens. So this is overall Pilocarpine had about 114 patients, and the vehicle, this is the same drug, the same vehicle had 116 patients. And now let's look at the Virgo. Again, very similar patients, 50-year-old white woman. Women were a little bit more than men. I haven't put women because the numbers are about 60%, not 70%. But you can imagine that almost similar looking patients in the two groups. Now, how many actually got to this 3-line improvement? So this is the baseline characteristics from the same study. So it's about 50 years, and women at about 60%, right? So this is how the baseline characteristics look like. At 1 hour, again the results are similar: 35% versus 8%. So about a third are seeing well when you set the bar high in terms of illumination. When you set the bar little lower, again 60%. So about 2/3 are seeing well. But they don't give us results from other time points. Interestingly, they don't give us anything about what happens in really bright light or photopic conditions. But at 3 hours, they actually say that it is 33%. That's like really low. So why would somebody see something going wrong, and I couldn't really find out why. So though they don't concentrate on these results, they primarily concentrate on some of these results. And what they have additionally provided us is something like this, where so this is 2-line improvement, right? So we are setting the bar a little low. So this is the 30% improvement line that I have drawn actually. So what they are really telling us is that it's most efficacious in 50-year-old women who are predominantly part of the study, with vision of N10 to N12, who is okay with if effect lasting for 4 to 6 hours, and who does not mind reinstilling eye drops. And when started, about 2/3, but not all, will get to N6, right? So if you see baseline, this vision, if it's worse, so 2063, that's about a little worse than N10. They had even more than 30% gain. More than 30% actually saw better, right? While the vision is already better at baseline, so N8 or N10, then they did not have that much benefit. Obviously, the vision is already good at baseline, right? So it is good for somebody who is nearing 50, and baseline vision is uncorrected vision is N10 to N12, and we need to tell them that 2/3 will improve. So you may or may not improve. Right, but then you may improve if you're targeting N6, but if you're targeting N5, again only about a third will improve. So this is the Virgo trial, and the adverse effects actually had some distance vision improvement, like we know it can happen. So this is graph from the study. So on the x-axis, you will see this is distance vision, CDVS, corrected distance vision acuity. So anything on the right of this of this vertical line is improvement, and these circles which are colorless are actually pilocarpine here. So a lot of patients are on this side, on the right side, or on the correct side. So a lot of patients actually had improvement in even distance vision, as we know can happen, and a lot of this is dependent on many factors, including how clear the lens is. The next study we'll look at is the NEAR study, which is the phase 3 randomized trial. What it really did is used 0.4%, not 1.25%, but 0.4%, and it used it twice a day, that is 2 hours post dose 1. You give it immediately, so you give it at 8 o'clock and then immediately give it at 10 o'clock. Remember, this is a very low concentration, and I showed you some studies in the beginning which actually use even 0.25%, right? So so what happens if you actually drop concentrations? Remember that perhaps becomes a little bit safer because the traction is a little bit less on the peripheral retina. So how did these patients look like? Now, these are little older patients, 54-year-old. Again, mostly were women, and almost everything else remains the same. At 1 hour, again about 40% had improvement. At 2 hours, this is the time point when the second dose was given, right? So here at 3 hours or 1 hour after the second dose, 50% actually had better. Again, this bar is set very high, right? So and at so overall, if you see these graphs, at 1 hour about 40% had improvement. At 2 hours, that drops slightly, but then you give the second drop, then again it gets better, right? So it goes to 50%, right? So the takeoff is a little slower. That's because it's slightly weaker drug, but then you need to repeat it. So is it worth repeating a drug immediately 2 hours later? Are patients going to be okay with repeating a drug 2 hours and then maybe again at the 6th or 7th hour or something like that? So it's going to be not twice but maybe thrice in a day, and that's something that we can debate about. But then if it's safe, we might go for it, but then overall long-term data are not available. When you look at, when you drop the bar, again, it's about a third of the patients are benefiting, and they don't report anything about what happens in photopic conditions or bright light. And so this is what they reported about. So as you can see, these are all the rates. This is at day 15 basically. So overall at 3 hours, at 4 hours also it's high, 70%, 71%, and then it gradually drops off. Right, so it's relatively sustained. That's because you're giving 2 drugs back to back. This is the effect on the pupil size, pretty similar. This is at day 15 again. Pupils, you see the pupil is coming back, and at that 3rd hour time point you're giving another drop, and again the pupil drops. And compared to the previous GEMINI trials, very similar results are seen. And overall side effects, not much. 7% had headache and nothing much to report about. So overall, all are very in sync with each other. Let's see, a study which was, this is screenshots just showing you that about 7% had headache. So far, most efficacious in about 50-year-old ladies, give or take, with a vision of uncorrected vision of N10 to N12, with effect lasting for about 4 to 6 hours, and doesn't mind reinstilling eye drops, right? And so this is, I'm just repeating it again. And 2/3 will have improvement if you're looking at N6, even in dim light. 1/3 will have improvement to N5. Even at 4 to 6 hours, and there are slightly weaker drops, 0.4 drops, which may also be effective, needs to be instilled more frequently. Peak effect occurring at about 3 to 4 hours, not sustaining quickly, and not dropping off quickly because you're reinstilling again and again. So this is unpublished data from clinical trials which has been conducted at home by NTOD, who is making drops and trying to make it in India. And I think we should all put our hands together and sort of congratulate them, because clinical trials don't happen very frequently, and a lot of pharma companies are perhaps not even looking at conducting clinical trials. So then so I think it's a good job done. Let's see what the trial said. So how did the ideal patient in this trial look like compared to all the other patients? These were predominantly 50-year-old, but men were more common. More than 60% were men, and then rest are all similar. Of course, the iris was brown. So this is how an ideal patient would look like. Very, overall the BMI is almost 25. So a lean 50-year-old individual who's quite fit, and this is how this is just a representation. This is how an American clinical trial patient might look like, and this is really how an Indian trial might look like. Other than gender, and pretty much all else is similar. Now, what happens to the primary endpoint? Again, about a third, if you set the bar very high, about a third are doing well, and then it's slowly waning off. What happens if you drop the bar a little bit? Say 2-line improvement. So this is just a graph showing the same thing. What happens if you look at 2-line improvement? Alas, that data is not there. At least in the trials and the material that I have obtained from the company, I could not find what happens if you just drop the bar. And I think this is really important for making decisions, because this is the one which is like the really clinical relevant, and we're looking at N6, right? And I think it's pretty good enough for most ophthalmologists. When you look at what happens in very bright light, this is more realistic, where 65% patients are seeing well compared to 90% in the GEMINI. That's like way too high. And like I said, this vehicle is doing something and bumping up these numbers is what I feel. But then, we don't exactly know. So, 65% are seeing very well at 1 hour, and that maintains at 3 hours. And then we don't know what happens. But still, 2/3 are going to see well if they are in bright light, which is the case in most offices and, most homes in India. So then, if you are just looking at this, the drugs works pretty well. In one of the figures they show this number to 76%, and this is not a reviewed manuscript, and perhaps there are some discrepancies, but it's very minor. And the side effects are again quite well tolerated. It's about 11% headaches at all mostly mild, and not much elsewhere. So when you compare across trials with a bar set very high, which is not even realistic from a clinical point of view, but then the FDA mandated that. So, it has been done and it has been reported. It's about a third of the patients, about 35 or so, will do well at 3 hours. But then if you drop the bar a bit, the number doubles. So about 2/3 will do well at about 1 to even 3 hours. Right. So overall, in the Virgo showed little higher numbers, and the next the near study showed even higher numbers. Right. So unfortunately, the Indian study doesn't have those numbers, but overall it's about 2/3. Right. So I think that's overall quite acceptable, and that adverse effect profile is quite tolerable. So far it is most efficacious in 50-year-old lady, with vision of N10 to N12 at 40 centimeters. So let's understand 40 centimeters is quite close and not at an arm's length. It's almost half an arm's length when we are measuring. And so most patients tend to sort of push it away, and then we allow them and say it's okay, you read how you can. But then from real application of trials, we need to actually enforce and tell them no, you need to read as close as possible. Then who is okay to with effect lasting 4 to 6 hours, who does not mind reinstilling drops, and when started 2/3, but not all, will get N6, and 1/3 will get 3-line improvement, and then there are little weaker drops which are not yet available. So this is the efficacy point of view. If we start with a clean slate, and not only efficacy but safety also plays a very important role in in how we look at clinical trials. Let's look at some of the adverse events, and sort of trying to take you a little bit away from this jigsaw and trying to give you a perspective. I'm going to take your mind out a little bit to one of the books that I have read recently, and it's called Thinking Fast and Thinking Slow by Daniel Kahneman, who is a Nobel Prize winner. And so he talked about the law of small numbers. Remember, because most clinical trials don't report outcomes which are bad, or somehow they are not followed enough, or those numbers are really small. So we are always looking at very rare events in terms of outcomes, right? So let's try and interpret and understand how to interpret these numbers. So this is a map from the US. This is not ophthalmology. This is about rates of kidney cancer. So this is the Midwest, and if you see, these are low kidney cancers, or low rate of kidney cancers in some of these states and provinces. So people say, oh, these are rural areas, and they may be eating better, and a lot of other things are happening in there. The air is better, there is no pollution, etc. And then when you look at the Midwest and see who are getting high, so these are highest rates of kidney cancers, you will see so people will say, oh, they don't eat well, there's a lot of pollution, they eat a lot of processed food, etc. And so when you compare across these, you will see this is how it is. But when you actually overlap these, so what's happening? So this is a very low, this is only the 1 out of 10 is getting cancer. Here like 7-8 out of 10 are getting cancer, but they're right next to each other. So how can weather impact, and how can pollution impact all of those? And if you see, all of these are like that. So what is happening here, interestingly, is the counties which have high rates have actually very low populations. Right, so the denominator is very important when we are looking at some of these rare events. So say this county has a rate of 20% kidney cancer. 20%, that's 1 in 5 men, but then their population is only 5,000. Right, so as the population increases, the risk of cancer is reducing. So imagine 3 out of 100 is 3%. 3 out of 1,000 is 0.3%. 3 out of 100,000 is 0.03%. The numerator remains the same. The denominator is enlarging. So if we are talking about retinal detachment, we need to understand out of how many drug doses administered did people get retinal detachment, or endophthalmitis, or anything that a rare event you talk about. Remember that the denominator is really important, and unfortunately, a lot of case reports don't talk about denominators. So the small counties have much larger variations than larger counties. When you repeat the same study after 10 years, you will see that 20% has dropped to like 3%. And then absolute numbers are almost, really, instead of 3, you might have 1. Right? So let's see side effect profile of pilocarpine based on some of these, assumptions. So this is a supplemental material from the GEMINI study, which enlists every side effect that was actually reported. So a lot of side effects which have been reported. Some of them are attributable, and some of them perhaps are not attributable to the drug. So some which are relatively large in percentage I have highlighted. So conjunctival hyperemia, it's large in this context, but overall it's not large. So 2.5%. When you look at this again, it's too many things happening, but headache is in 14%. And here again, too much where you don't know where to look for. Visual impairment, that is distance vision, is low in 4.3%, and also they have a different category of vision blurred, which is again 2. So overall about 7% have distance vision which is being blurred a little bit. So that it's less than 10. So 1 out of 10 will have that little bit of problematic area. And visual field defects, that we think about, everything is getting constricted. Remember, this is at 30 days. It's not like a year out. But then still, visual field defect was not really a concern at day 30. We don't have long-term data as yet. Let's look at overall retinal detachment. There have been let me quickly go back to this video on accommodation and understand the mechanism of retinal detachment. So here, when the ciliary pupil contracts, the posterior zonules contract and the anterior zonules relax, and this is causing traction on the peripheral retina. Once the effect of the drug is gone, this relaxes, posterior zonules relax, anterior zonules contract. I'm going to quickly play it again. This is relaxed. The lens has become more increased in anterior posterior diameter. When it relaxes, this contracts in the posterior. So this is basically where the pathology might happen, and you could have tears. Now there are 3 case reports, or you can even call them total of 5 cases which have been reported post post 1.25 pilocarpine, and all have of course been Vuity. So this is one paper which talks about 2 cases, and I know Rajesh Rao quite well, and they talk about 2 cases. One is 65-year-old, one is 72-year-old. Both are pseudophakics, and one had high myopia. When you read the full text, you will realize that perhaps there are a lot of other confounders going on. When you look at this study from Harry Flynn and the group from Bascom Palmer, they talk about 2 cases. One had bilateral RD. Out of that, one eye was pseudophakic. The other wasn't, of course. And then the third eye, or the second patient of the third eye, had myopia of -4 or -5. So again, there is something going on at the bottom, there. And then some people have talked about vitreofoveal traction actually worsening. That's when the fovea is quite posterior, so it's perhaps causing a posterior vitreous detachment of some sort. So overall, I think examine the periphery well and don't advise if the patient is more than -5 spherical, the sphere, because clinical trials actually excluded them, and perhaps there is a reason why we should as well. And any risk factors for retinal detachment, you need to advise against pilocarpine, say if there is a family history or there is high myopia, like we already talked about, and there are lattices and some of the other things. So look at the periphery well. And remember, long-term risk of repeated therapy is unknown. The risk of incidence is also unknown, because we don't know out of how many got retinal detachment. There are some other studies which talk about compromised visual field and reduced night vision, and that night driving performance is affected, and this is understandable and could happen, and therefore I think we need to sort of discuss this as well. And do you drive regularly in the night with patients? Remember that about 7 to 10% will have blurred distance vision as well. It's not just near vision improvement. It could be at the expense of blurred distance vision. And if that is happening, again, perhaps patients will discontinue that themselves, but then, they might come back to us as well. And others, there are some talks about lens opacity and cataract worsening, because pilocarpine binds to melanin, and then this complex will alter the there are some animal studies, but in humans we don't know whether this is going to happen. And non-mydriatic pupil, and it's not a non-dilating pupil, rather after chronic use, this remains to be seen and actually might happen, but then we don't know. There is acute risk of angle closure glaucoma attack. That's because the lens is that the lens is increasing in anteroposterior diameter, so the AC is actually shallowing to about 12 to 15%. Though it is used for treatment, it could also precipitate in those who are very shallow AC. So we need to be a little bit mindful, but that's not common again. And remember that a lot of glaucoma medications develop tolerance, or anything we keep repeating over and over again, including diabetic medications, include intravitreal injections, including drops. The body somehow tends to develop tolerance. So this could also happen overall, gradually reducing efficacy with time. How long, we don't know that. Right, so remember that when you're looking at adverse events, think about Kahneman and that all the research that he has done, and that it could be one that you are seeing, but then it could be very rare in general. So these are some things at the back of our mind which should always be there. So we've talked about safety, and we've before talked about efficacy, and all of these. So what are the take-home messages, or so what is it that we want to take home? So let's put it all together. First and foremost, when you are examining, we need to see it, and remember that it's most efficacious in a 45 to 50-year-old, perhaps a lady, or even a gentleman, has a distance corrected but uncorrected near vision of about N10 to N12 in a photopic light, that is in a well-lit room, that is most of our clinics, at 40 centimeters. The patient is not myopic, is phakic with a clear lens, it has a healthy retinal periphery and no risk factors for retinal detachment, and baseline pupil, it's better that it's a little bit larger, 3.5 millimeters. So we don't have pupillometry in all clinics, neither do we have ASOCT. But then you can look for brisk reactions. Pupils that react briskly will, very likely have very relatively larger baseline, pupil sizes. So if these are there, then we look ahead. Then we discuss with patients: is it okay for them to have an effect lasting for 4 to 6 hours only, and who does not mind reinstilling eye drops every day to sustain near vision gains, perhaps more than once, and who does not drive at night regularly. I think these are some of the points which we need to bring it up. And lastly, we need to inform the patients about what is expected, right? So when we start, 2/3, but not all, will get N6. We've already discussed this before, right? So 2/3 will get N6 if starting from N10, even in dim lighting, and about a third will still get to even N5 with dim lighting at 4 to 6 hours, provided they have high contrast background. Majority will get N6 in brightly lit rooms for 4 to 6 hours, but then you'll have to repeat. It's like if you start at 8 and nobody works for 4 to 6 hours, right? Most work for about 8 to 10 hours. So then what will happen if you are at work at 2 o'clock and your drops effect is gone and you're stranded? what do you do? So you have to carry your spectacle, or you need to carry the drop. One of the two is mandatory. So the choice is theirs, but then it's a bit cumbersome overall, but that's how it is, right? And risk of complications, though low, it still exists. So long-term data are not yet available. So we need to tell them that we have sort of ruled out all these risk factors, but still possibility of risk is the complication still there, and there are perhaps even dilute drops which might do the job. You might have to even put it more frequently. They're not yet available. So overall concluding statement is pilocarpine in presbyopia does not benefit all. We need to select well. Patient the effect will wane off. So repeated instillation is very necessary. Side effects, though rare, can still happen with long-term use. There may be a compounding effect, and so we need to watch out pretty carefully. And then patients to choose with physicians, not over physicians, and definitely not over the counter, because we know that total ophthalmic examination is, especially the retinal periphery, is really important before we go ahead and prescribe these drops. So these are some of the guidelines I thought, or sort of caveats which we can remember when we are prescribing presbyopia. Feel free to get in touch with me if you so wish. Thank you so much.